This program is made by MPT to enrich the diverse communities throughout our state and is made possible by the generous support of our members. Thank you.
From Maryland Public Television, this is Direct Connection with Jeff Salkin.
Good evening. Welcome to your Direct Connection. Tonight, as former President Biden begins treatment for an aggressive case of prostate cancer, we get answers to your questions about the tough decisions that face many patients. Joining us to discuss your health is Dr. Minhaj Siddiqui, Director of Urologic Oncology and Robotic Surgery at the University of Maryland Greenebaum Cancer Center and Professor of Surgery at the University of Maryland School of Medicine. Doctor, it's good to have you back on MPT.
Oh, it's my pleasure to be here. Thank you for having me.
It happens to be Men's Health Month, so this is a good topic to cover. Apart from skin cancer, this is the #1 cancer in men. Tell us what men need to know.
That's absolutely right. You know, I think that there's a lot to know, and I think that it all starts with being proactive. This is a disease in which there is a lot you can do to see what your risks are, and also get screened and check that if this is something that is going to affect you. And there's the most important thing with prostate cancer. We've come a long way, and there's a lot that can be done for this cancer, and so there's a lot of reason to be proactive.
The numbers are crazy. I read that in a study of autopsies of people who died for other reasons, car crash or whatever, men in their 80s, if they took a look at the prostate, about half the time there was cancer there.
Yeah. No, we've come a long way with prostate cancer, understanding this disease. And so it does turn out that most men will get diagnosed with this cancer if you wait long enough.
If you live long enough,
If you live long enough, yeah, it's a disease of aging. And so we've come to appreciate over the years that not everyone that gets prostate cancer has to be treated for prostate cancer. We've become more discerning about who we check for prostate cancer, and when we check them, and when to be more proactive because we can actually cure the disease, or actually back off because it's not something that's going to cause any kind of meaningful impact on the longevity of the person.
People do die of this every day. It's a relatively small number compared to the number of people diagnosed. It's like 300,000 people diagnosed a year, 30-some thousand actually die of it. And in fact, the last time you were here, it's about 5 years ago when Mike Miller, who was the president of the state Senate, had died of prostate cancer. So just because it's slow growing and common doesn't mean it can't be serious.
Absolutely, yeah. I mean, I think that this is important. Sometimes, as you said, 90% of prostate cancer diagnoses are not lethal, but 10% are. And because of just the sheer numbers of people that get these cancers, even though it's 10%, it's a small percent, the overall prognosis is excellent, it still ends up being a lot of people who do pass away from this disease. It's about the third most common cause of cancer death in men.
And when you're looking at somebody's particular risk, I mean, family history plays a role, ethnic history plays a role. People of African ancestry have much higher numbers, right?
Yeah. So I think that there's a couple of risk factors involved that you should be aware of, and these actually influence how proactive you are about getting checked for prostate cancer. And so certainly black men are a 2 to 3-fold higher risk of getting aggressive cancers. Also higher risk are men who have had one family relative who had aggressive lethal prostate cancer, breast cancer on their mother's side at a young age, 50 and younger, ovarian cancer, or pancreatic cancer, or multiple family members who've had any kind of prostate cancer diagnosis, so brothers, uncles, and fathers, and whatnot. And those are all considered in the high-risk category for having familial prostate cancer themselves.
PSA is the common screening technique. What is it? How's that work?
Yeah, so PSA is a blood test. And PSA itself is not a toxin. It's not dangerous. It's not sometimes people get the high PSA and they worry, how do I get the number down? But it's not that the PSA is dangerous. PSA is made by normal prostate, but it's also made by cancer. And cancer makes more of it. So if you have a high PSA it may be because of prostate cancer, and that's what you really want to make sure. It can also be because of inflammation or infection or a big prostate. And so there's a lot of reasons why the PSA can be high and it's not a problem, but it's a blood test that you do, and it's to essentially check to see if you might have prostate cancer.
The really tricky thing here is who gets checked.
Yeah.
It's not expensive, it's not invasive. If you're getting labs anyway, it's nothing. But then you get into these questions of what to do about it. What's your best advice these days?
So this is an area, I'm glad we're bringing this up, because this is an area that has really evolved, actually, over the last few years. And so, you know, I had the pleasure of being on your program 5 years ago, and actually, if you play what I said then and what I said today, it's evolved. The guidelines, there's major guidelines, the NCCN, National Comprehensive Cancer Network, and the American Urologic Association. They've changed their guidelines in the last year. And at this point, the guidance is to get started checking either at the age of 40 or 45, which is much younger than it used to be. And 40 if you're a high-risk category based on some of those things that I just mentioned earlier with like race or family background. 45 otherwise, just to get a baseline. And if the baseline is elevated, greater than 3, which is actually a different number than 4, it used to be 4, then to get it worked up or do more regular checks. And if it's low, then to do less frequent checks. So there's a lot more kind of adjustment going on now.
The famous quote by John Wanamaker, who started the Wanamaker's department store in Philadelphia, this is maybe a century ago. He knew that half of his advertising budget was wasted, he said, but he didn't know which half. Mm-hmm. It's a little like that with prostate cancer, that you wind up taking out a lot of prostates, some of which might have killed somebody, but some of which would not. And we don't really know at this point, do we?
That's right, yeah. I mean, I think we're still working on it, but that's part of some of the changes that have taken place in the last 10 years. And so we now have so many more tools. We have advanced imaging, we have MRI imaging and PET scans and genomics and biomarkers. And all of these things really kind of come together. And the culture of trying not to do the most radical treatments and doing less invasive treatments, focal therapy, robotic surgery, focal and you know, highly kind of targeted radiation therapy. All of these things have really improved decreasing side effects and active surveillance, actually, just keeping an eye on it, minimizing treatment on people who don't need it, or minimizing side effects in people who just need intermediate levels of treatment as opposed to aggressive treatment.
Reminder, viewers, if you have a question about prostates and prostate cancer that you'd like us to look at, send an email to livequestions@mpt.org. One of the things about the Biden case is that they've disclosed that the former president has a Gleason score of 9. What does that mean?
Yeah, so once one is diagnosed with prostate cancer, one of the first things that happens is we try to figure out how aggressive is it, and that helps cater the type of treatment that we offer that person. And so there's something called a Gleason score, which is a aggressiveness score, and it's an unusual number. It goes from 6 through 10, but his being 9 does put him in the high-risk aggressive category.
The other mystery of the Biden case, well, some people were suspicious that it was diagnosed at a late stage, sort of out of the blue, from somebody who had regular checkups as president. But in the screening regimen that we were talking about, somebody in his age bracket, he's 82 now, when he was in his late 70s, they wouldn't necessarily have screened for it.
Yeah, yeah. And there's a number of factors that come into play here. So from what I've seen in just like the press reports and whatnot, it sounds like he had his last screening done in 2014, 10 years ago, more or less, which would have made him in his kind of early 70s, 72, 71, somewhere around there when he stopped screening. And 2014, that was the guideline, to stop screening when you hit 70. And that was there was more of a debate to actually stop screening altogether for prostate cancer. The pendulum has swung. You know, it swung all the way to the point that people were saying PSA is not something that should be done. And it's come back quite a bit now, because now we have ways to cater treatments and cater workup. But when the decision was made for him to stop screening, that was part of it, is to actually, that was the best advice at the time. Even today, past 75, there's a lot of adjustments that are made on whether screening should continue or not. And it's also worth noting that just because he's been diagnosed with an aggressive cancer, this is still a cancer that tends to take about 10 years to be lethal. And so for an 82-year-old man, that puts him squarely in his 90s. And at that point, competing risks of death to start to kind of play a factor. So it's unclear whether this will truly have a long-term impact on his longevity.
The next dilemma for somebody who's decided to get a PSA check and it indicates they need a biopsy and something is found, let's say it's an average level of aggressiveness, is what do you do? Do you go to surgery to have the prostate removed? Do you go to radiation to slow it down or kill the cells? Or do you do something called watchful waiting, which is nicknamed watchful worrying?
Mm-hmm.
What do you tell patients?
You know, and this is where you need to build your team. You know, I think that there's people out there who will help you with this. And so, you know, whether the most important thing I tell patients who are newly diagnosed with prostate cancer, especially the one who are given multiple options, is to get the opinions. Go to a urologist, go to a radiation oncologist. You know, in some cases, you may even want to go see a medical oncologist and learn about this disease. It's not a disease where you have to make a decision in a week or 2 weeks. You do have time without causing any change in your outcomes, and learn about what it means to get surgery, learn about what it means to get radiation. In some situations, you'll be told that there is a right answer. Surgery is the best answer, radiation is the best answer, active surveillance, watchful waiting in other scenarios is the right answer. In other situations, you'll be told you have 2 options or you have 3 options, you know, and then you have to understand what they mean to you, and based on kind of your values and your preferences, what's the best choice for you.
Let's look at some email questions. This is Paul, who asks, is there any relationship between an enlarged prostate, which is another topic, and prostate cancer? I think it was King Charles in England who went to surgery for an enlarged prostate. They found some other cancer, but I don't believe that was prostate. Anyway,
Yeah,
forget the king. Let's talk about enlarged prostates, and does that lead to prostate cancer?
Yeah, so no, this comes up a lot, and the quick answer is that typically not. The enlarged prostates can cause your PSA to come back high, and so there is always a confusion that comes in, you know, when a high PSA comes up. But enlarged prostates cause urinary problems, and there are prostate surgeries that remove part of the prostate to kind of like an apple core to make it easier to urinate. Whereas prostate cancer requires removal of the entire prostate and is somewhat of a distinct entity.
Can diet and exercise help keep someone's PSA in the healthy range?
So, you know, the key underlying aspect of this question is not so much keeping the PSA in a healthy range, but preventing prostate cancer, right? Because all we're using PSA for is to detect prostate cancer, and PSA itself is not dangerous, but you want to just make sure you don't get prostate cancer. And generally speaking, there is emerging research to say that people who live healthier lives, who maintain healthier bodies, probably do prevent some cancers, potentially including prostate cancer. But there's no definitive answer on this. There's no definitive diets and whatnot. But just as being healthy, not overweight, obese, is good for your general health, it's probably good for your cancer prevention as well.
A viewer named Anne writes to share that her husband died of this disease and asks, why can't you just remove the prostate before it's an issue? And there are side effects.
Yeah, that's what it comes down to. And the challenge is that prostate cancer treatment itself does have significant side effects in the urinary and sexual domains, and these can affect your quality of life significantly. And so it's not typically something that we have done prophylactically. Instead, what we recommend in patients who are high risk is being very proactive about screening, monitoring for prostate cancer, and trying to catch it early if it affects you.
One personal note on this subject, I had the surgery in 2022 and was really fortunate because it was a year or 2 after your last appearance to be able to call you up and ask you and make an appointment and actually see you professionally. So that's thank you, number one. is that you really won't find anybody out there with a better combination of credentials and communication skills than Dr. Siddiqui and his team at Maryland. Thank you number two is a guest who was on this show 20-some years ago when we started doing Direct Connection. We had Patrick Walsh, professor at Hopkins, who was the inventor of the nerve-sparing prostatectomy and a hero to men everywhere. Recommend his book on living with prostate cancer. There's information everywhere, but his book puts it all in one place. The third thank you is that there's a video out there with Cal Ripken. This is maybe 4 or 5 years old, talking about his experience with prostate cancer, his decision to go to surgery. And you know, Cal Ripken is somebody, I think every man in America looks up to Cal Ripken. So to hear Cal talking about going through the process, making a decision, he elected surgery, as did I, had a good result, I think helps a lot of people, because people struggle with the complexity of this issue, whether you're going to get screened, if a problem's found, what do you do? And it's a tough one.
Yeah, you know, I mean, I truly commend you for kind of being public with your history and your diagnosis. I think it really helps. I think it really helps men. I mean, I think that you see people who you can relate to, whether you speak of Cal Ripken or yourself, you know, now kind of mentioning this. I think that having that relatability reminds men that, you know, be proactive, go out there, get checked. You can do well. You know, it's great to see you doing so well, and others can do well too. And it's just a matter of being proactive and getting themselves checked.
The other thing I see, just staying in touch with the public media and the research on the topic, is how fast things change. It's stunning. I mean, we talked before the program how it's good to have a condition that a lot of people have because there's a ton of research. We haven't talked about these new MRIs, multi-parametric MRI technology.
Yeah.
It's right on the money, or at least it was in my case.
Yeah, I mean, we've gone, in my training, we've gone from when we were blindly guessing where the cancer might be, kind of like a battleship style, to now precisely targeting within a millimeter or two the area that looks concerning and being just much more precise, much more accurate. It's come a long way, and I think there's still more and more coming out. And so I think outcomes are only going to get better, and all the more reason to really stay kind of proactive about this day.
One of our viewers had a question about hypofractionated radiotherapy. Newer technique?
Newer technique. I mean, I think it's been around, and this is more of a radiation oncologist specialty area. So I live more on the surgery side of this. But essentially, getting radiation used to mean going 5 days a week for 2 months to get radiation treatments. Hypofractionated allows you to go for fewer treatments and get the same dose of radiation safely, and it makes it less onerous to get the treatment.
Somebody told me in my process, and I was fortunate to have good insurance and got multiple second opinions on this stuff. And this was an oncologist who said if you, and my situation was, it was just past being able to do the watchful waiting thing. So it was either going to be surgery or radiation. Wound up choosing surgery, but the advice was if you choose surgery, get the best surgeon. If you choose radiation, get the best machine. I don't know if the radiation people see it that way, but if somebody's at that stage of the process, how do you decide who to see? I guess any urologist can technically do the procedure, has done the procedure.
Yes, although I think that there's some benefit to going to centers where there's expertise, where there's multidisciplinary care, where you will be able to kind of meet the various specialists involved. I think that going to a surgeon who does this recurrently, not once a year,
Right.
is beneficial. You know, I think you get good at whatever you do repeatedly. And I think that, and a lot of it's nuanced. A lot of it, I think that there's plenty of surgeons who do just a few of these procedures. I think ultimately you want to also meet the doctor and feel trust in that doctor. Feel because it's a journey. It's not a one-time encounter.
Well, let's see what we have here. That one may be too complicated. Well, here's a question, and I've read this. How does regular or irregular sexual functioning play into the cause or prevention of prostate cancer? That was a decades ago argument in terms of the amount of, let's say, activity being somehow protective against developing prostate cancer.
There's been studies on this. It hasn't borne out. I think that's the quick answer on this. That there may be indirect associations, relationships that are uncovered by looking at the kind of sexual activity and cancer outcomes. But at the end of the day, it's not what we call causative, that one doesn't cause the other. They just kind of seem to cluster together. And so I think at the end of the day, there's no meaningful underlying relationship there.
We talked earlier about the prevalence being substantially higher among men of African descent. Do we have any idea why? And how does that change the screening recommendations if you're a member of that community? Yeah,
this is very well studied and yet still not understood. And so the fact that black men have a higher risk of getting prostate cancer and aggressive prostate cancer is well known. One in 7 or 8 men generally in the United States will get prostate cancer. However, amongst black men, it's closer to 1 in 5, the risk. And so why? It's probably some degree of genetics. The genes that exist amongst that community may predispose them to getting more of this cancer. Certainly, we know that genetics plays a role in many people, not just black men. People, families that tend to inherit prostate cancer pass it on to their kids, and so. But which gene specifically has really eluded the scientific field even to this day.
Does the level of aggressiveness differ at all?
They tend to be a little bit more aggressive too in black men, and so that and accordingly, the guideline recommendations are for black men to start screening at least as a baseline entry-level PSA at the age of 40, which is different than the general population, which is 45.
So University of Maryland Medical Center, Greenebaum Cancer Center in a big city academic medical center environment, how can you help the community in Baltimore, in your part of West Baltimore, deal with these disparities and make sure whatever's going on, it's not because of a lack of access to quality health care?
Yeah, I mean, that's a great question. I think that's very much part of the mission of the medical center, and I know that there are teams, and I've been involved with helping them, which have tried to build ties with the community, ties with underserved populations within the city and in the state itself, setting up screening drives, setting up awareness campaigns, and whatnot. And I think that all of these programs like this, right, and our relationship, the University of Maryland's relationship with this program, and getting the word out on just understanding that certain populations are at higher risk, and what you can do about it and how you can do well from it. All these things I think help.
Most of the time when we interview your colleagues, the School of Medicine and the Medical Center, one of the questions I have to ask is what are the symptoms of this condition? Mm-hmm. In this case, what I've read is if you're having symptoms, it's already pretty late. You want to catch it before you have symptoms. Yeah. But what would the symptoms be, and could they be something else other than cancer in the prostate?
So this is quite timely because how was President Biden caught? Through symptoms. He was having urinary problems, and that's what led to the diagnosis of advanced stage prostate cancer. So this is very much, I think, a visible case in point that advanced cancer presents with symptoms, early stage cancer does not. And so people who say, I feel fine, I don't feel any pain, I don't feel any urinary problems or any other type of problems, sexual problems, pain, That's because early stage cancer doesn't present with those issues, but late stage cancers do, late stage prostate cancer specifically. In those situations, you can get difficulty urinating, bone pain, if it's spread, weight loss, all these types of things. But that's typically, it's not curable at that point.
So unfortunately, the former president's in that situation, but it is an opportunity to raise awareness. And in half a minute, what do you want our viewers to know about prostate cancer? I
think that, yes, unfortunately he's in a situation, there's a couple things. So in his situation in particular, even though it's not curable, it is very treatable. And there's many very effective treatments that can maintain a very good quality of life. And for people who are in the kind of earlier stage of their life, in their 40s and 50s and 60s, the main thing is to be proactive about your health, get checked, and try to catch this thing. If you're going to get it, try to catch it early where your outcomes are excellent. Dr. Minhaj Siddiqui, University of Maryland Medical Center in the University of Maryland School of Medicine. Doctor, great to see you again. Thanks for your time. Thank you for having me. Appreciate it. That is Direct Connection for this week. We're back Friday with State Circle and the latest on Maryland politics. Join us for that Friday evening at 7. Now, for all of us at MPT, thank you for watching Direct Connection and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.